What if one of the key drivers of cardiovascular disease isn't just high cholesterol, but a toxic form of oxidized cholesterol that our bodies struggle to clear? Imagine if we could selectively remove it and in doing so actually reverse some of the damage already done. That's exactly what today's guest is working on. Hey everyone, welcome back to Decoding Longevity. I'm your host Raghav Sehgal, joined with my co-host Macsue Jacques.
Hi, everyone. In our last episode, we have explored decentralized science and N-of-1 trials with Jasmine Smith, CEO of Rejuve. Today, we are switching gears to cardiovascular aging, diving into a fascinating study on 7-ketocholesterol or just atherosclerosis plaques, a major culprit on atherosclerosis and a new therapeutic candidate that targets it. And to help us break this down, we are joined by Matthew O'Connor, a researcher leading this work in a well-known figure in the longevity field. Oki, welcome to the podcast.
Thank you so much, Raghav and Macsue. It's really great to be here with you.
Yeah. So let's start at the beginning, okay? Most of our listeners have heard about cholesterol and its association with heart disease, but not maybe about 7 keto cholesterol or this oxidized version of cholesterol. Can you explain what it is and why it's so harmful?
Yeah. So, cholesterol is one of the essential building blocks of life. Every cell in your body has cholesterol as a part of the membrane that holds your cells together. And without it, your cells would just fall apart. So we need cholesterol. Most people only think about cholesterol from a heart disease perspective about the so-called bad cholesterol, which is LDL cholesterol or low density lipoprotein cholesterol, which is actually not cholesterol. People mix them up, but they're actually completely different from each other. LDL is a transporter for cholesterol, and it's enormous. It has a weight of 2.5 million Daltons, and cholesterol has a weight of less than 400 Daltons. And your average LDL particle is carrying about 1,500 cholesterol molecules around. So the so-called bad cholesterol is actually a truck that carries cholesterol around. When that gets oxidized, or the cholesterol that is already in your cells and in your tissues gets oxidized by random free radicals, which are everywhere. Every place that you have oxygen, you're going to have oxygen-free radicals. That damages things. It damages the metal that you see in cars from rust reactions. And so when you have these oxidation reactions, it damages cholesterol. It can damage lots of molecules, but it damages cholesterol in a very predictable way, leading to this 7-keto cholesterol, which is kind of a mouthful. I usually just say oxidized cholesterol. And it's very atherogenic, it's very toxic, and it's completely useless. You don't need any of this oxidized cholesterol in your body. The optimal amount is 0, unlike LDL cholesterol, which you need to distribute cholesterol through your body. You can have too much of it, but with oxidized cholesterol, any amount of it is more than you need.
Yeah, that is very interesting. I love the analogy with the trucks, transporting everything else. So really, we need it. The problem is that they're getting, oxidized. So you described in the paper how 7-keto cholesterol doesn't just accumulate, but actually transform macrophages into foam cells and plaque formation. So how big of a role does this play into the atherosclerosis compared to the traditional risk factors?
Well, the foam cells build plaque. They build the soft tissue that is the plaque that builds up in your blood vessels, which develops atherosclerosis. Now, that's not the only thing that goes wrong in your arteries as they age and as you develop atherosclerosis. It may be the most primitive event, and it's what creates the mass of it. Now, there's things that happen after that, the hardening and such like that, and the calcification. But the earliest stages are when you get a small lipid lesion in your blood vessel. Macrophages go there to try to clean it up. When they eat too much oxidized cholesterol, their lysosomes shut down. They stop being able to metabolize lipid, and they just start ballooning up into these nasty things that are called foam cells, because they look like big blobs of fat, because that's what they are and what they become. And so that is a feedback loop where you get these macrophages that come, they get converted into foam cells. by oxidized cholesterol, then more macrophages come and try to clean up that mess, because macrophages actually eat macrophages quite frequently. And they come and they try to eat the foam cells, and then they turn into foam cells, and then they just like grow and grow on top of each other, and that's what like builds the mass of the plaque. That's why we think that that's like the most important step to intervene in atherosclerosis.
Yeah, that's really interesting, actually. So there seems to be almost like a recursive reaction there with the macrophages sort of consuming this oxidized cholesterol. But in your paper, you actually show that by selectively sort of removing 7-keto cholesterol or the oxidized cholesterol, you can actually revert these foam cells back into macrophage-like cells, which is incredible. It's almost a reversal of disease. But can you walk us a little more through the exact mechanism that happens? Because these macrophages have still sort of consumed some of these 7-keto cholesterol, and how does it really reverse back?
Yeah, and this was a really surprising part of the study, and why we think it's pretty big news, because foam cells are, if your audience, this is an aging program, so your audience has probably heard of senescent cells, right? And if you know the history of senescent cells, part of the definition of cell senescence, which I worked on when I was a graduate student, and I've had my eye on for most of my career. Part of the definition is that it's an irreversible transition from being a normal, healthy, metabolizing, classically replicating cell to a cell that will never replicate again and has this senescent phenotype, which is big and complicated. And most importantly, part of that definition is that it never goes back to being a normal, healthy cell. And that's the same as a foam cell, which you could consider to be a kind of senescent macrophage. I know the term senescence gets a little overexpanded sometimes, so I'm not trying to create a new definition, but it's a good analogy. And there's a lot of similarities between foam cells and senescent cells. And so that's the same thing. Foam cells never go back to being healthy, normal macrophages. To my understanding, we're the first group to demonstrate the reversal of the foam cell phenotype. And the cool thing about this, from my perspective of very specifically working on targeting this oxidized cholesterol, is that the lipid that these cells are full of is all kinds of fats. It's not just the oxidized cholesterol that we gave to trigger this transition. We can trigger this transition to being a foam cell by just giving them a little bit of oxidized cholesterol. What most people have done traditionally over the last few decades of experimenting on foam cells in a dish is to just overload them with lipid and just give them tons and tons of lipid, and then they turn into foam cells. We just give them a tiny bit of oxidized lipid, they turn into foam cells very quickly and start accumulating all this fat. And then we selectively remove just the oxidized cholesterol. So we're not pulling all that fat out with our drug. We're only pulling out the oxidized cholesterol. And then the macrophages go back to knowing how to process the lipids that are there. So they turn back on their ability to process the lipids through a process called reverse cholesterol transport, which macrophages are really, really good at. But that gets turned off in foam cells. And so we showed that not only do they stop looking like foam cells, but they start acting like healthy young macrophages again. And they start doing their job, part of which is to metabolize lipids.
Yeah, that is really incredible. It really sounds like we're moving just beyond slowing down atherosclerosis formation, but really removing, the cells or the oxidative cholesterol that is generating this foam. So that is really, really cool. So to actually reverse this disease process, how do you get this to select just the oxidized cholesterol? And what is it that you found that, I guess you touched a little bit about it already, that you can completely reverse this process to get healthy macrophages again. But what was the part of it that it makes you most excited about it? And I guess, how do you go from a dish to an actual patient itself?
Well, first you test it, carefully in some animals for safety and pharmacology, which we've done. We published most of that work in the in the paper you were referring to. And then you do a really, really good, careful job with the manufacturing process, which we've done. And you produce a bunch of super high quality drug material, and then you apply for permission to a federal regulatory agency. In our case, it was in Australia, and you get permission to test it on people. And so that's what we've done, and that's what we're doing right now. We're testing our drug in human beings in Adelaide, Australia.
Yeah, well, that's exciting. And let's talk a little more about this therapeutic candidate that you're right now almost in the process of running through the clinical trials. Could you talk more about this drug and the compound designed to do it? And how is it, again, we know you have talked about the mechanism, but how is this sort of depleting 7-keto cholesterol? And of course, how would you see this as being significantly different from the statins and other cholesterol lowering therapies that are out there?
Yeah, so all of the cholesterol lowering therapies, the statins were the first class of them, and then there's been two other fundamental classes of cholesterol lowering therapies. They're actually LDL lowering drugs, and the idea is that if you have less circulating LDL being the delivery truck that's delivering cholesterol to cells, then you're going to absorb less cholesterol into the blood vessels, and that's been shown very gradually to play a role in your risk of developing plaque as you age. And if you can reduce it, then the plaque will grow more slowly. What we're trying to do is get rid of the only the most toxic form of cholesterol, so that the macrophages can process all the LDL that's there. You can't get rid of all the LDL, like we talked about before. You need it to survive. And there may not be a way to like completely control atherosclerosis by just lowering your cholesterol. In fact, like, it's well established that people who get their LDL cholesterol to super low levels, they can still die of heart attacks and strokes, and their plaques can still rupture. So we want to get rid of those plaques. Our drug was designed. Our drug is a little bit unusual. It's pretty big, and it's like a cage. It's almost like Pac-Man, and it was built to encapsulate a single molecule of oxidized cholesterol inside of the drug. And then what happens after it does that, it can pull it out of cells or tissues, and then it floats away through your bloodstream and goes to your kidney, and then you pee out both the drug and the single molecule of oxidized cholesterol. So it actually has a very simple mechanism of action, which is that one molecule of the drug finds one molecule of oxidized cholesterol, and you pee that out. And once we've cycled enough of the drug through you, we'll get rid of all the oxidized cholesterol, and hopefully that leaves your cells, especially your macrophages, a lot healthier for it.
Yeah, that is very interesting. I guess there is a lot of like potential for beyond just the cardiovascular disease itself. And I guess, being the cardiovascular disease is one of the biggest killers in the, in the aging population, I guess there's such a large application in aging itself. But maybe could you expand a little bit more, like how do you see this helping potentially in other age-related conditions? Do you think that might have an effect in other things that come with age?
Yeah, absolutely. So my background is all in aging. I'm not a cardiologist. I'm not trained in cardiology or really anything cardiovascular. So we didn't precisely set out to cure atherosclerosis. We set out to remove, to remediate, to repair one kind of damage through like a divide and conquer sort of approach that accumulates with age. And so oxidized cholesterol is toxic in every cell that it encounters. It's toxic in your brain, where you have the most cholesterol anywhere on your body. It's toxic in your eyes. It contributes to macular degeneration. It's toxic in your liver. It contributes to liver failure with age. And so these are all things that we're looking at as potential applications for our drug. So we've really invented what we think of as an anti-aging drug, and figuring out all what diseases that it might help with. That's not to say that it's going to single-handedly cure all those diseases that I just mentioned. All those diseases are multifactorial, and we'll need more treatments, more diverse treatments to tackle the different aspects of aging that's causing them. But we are looking at trying to test our drug, for example, in Alzheimer's disease patients. So I think there's a lot of potential in many aspects of the chronic diseases for a therapy.
Yeah, and that's really exciting. You mentioned that you are already sort of working towards or in clinical trials right currently in Australia. Can you tell us about this choice to run your trials in Australia? You're based out of California, but running trials in Australia. What was so enticing about Australia, and what the current status of the trials looks like?
Yeah, so Australia is a really common place to run early stage clinical trials these days. A lot of companies, big and small, run clinical trials there. The government has created a set of regulations and incentives that make it a super good place to run clinical trials. There's tons of services that are in place. There's tons of companies that help you run clinical trials. Most importantly for us, though, when we recruited our clinical advisory board, one of our top cardiologists is named Dr. Stephen Nichols. And he was the second in command at the Cleveland Clinic in the United States for many years. And then he got recruited back to his native Australia at Monash University to run the Victorian Heart Institute and the new Victorian Heart Hospital that they basically built for him to run. So he's this huge guy who kind of wrote the book on plaque buildup, and we got him to be one of our advisors. And once he came on board and we were at the stage of trying to choose where to run our trials, he's like, you got to come here. Like, I've got everything perfectly set up for you to do this. I'll pave the way for you. I'll smooth it all out. And he's done absolutely that. And he's the type of guy that the big drug companies bring in their late stage phase 3 drugs to try to get them over the line for cardiovascular drugs. And we're just so lucky to have Steve Nichols working on our drug at its very first step. And so that's the main driver of us doing it in Australia. So the second part of your question, and I apologize for taking so long to get to it, was how's it going? I don't have any official results to say here. So, but like legal disclaimer, I've no results to reveal yet. I can say that our drug has gone through the dose escalation, all the way through the dose escalation in healthy volunteers. And so it was being tested at 6 different dosing levels. So at an extremely low dose and then higher and higher and higher, all the way up to a 6 dose. And it was done in 2 different ways, which is each volunteer getting only 1 dose and then each volunteer getting 6 doses over the course of a couple of weeks. And now we're just actually in the very last group of those volunteers at the highest dose, getting the 6 doses. So we're almost done with those healthy volunteers. And then we already have permission to go straight into the patients with plaque in their arteries near their hearts in next month. Hopefully starting dosing late next month in October. And so that's another advantage that that doing it in Australia gave us, was the design of the clinical trial protocol allowed us to build in these sort of tiered permissions where at each point, if it was safe, we could automatically go to the next dosing level, the next dosing group, and even go on into patients. So while I can't officially proclaim our drug safe, you can see that it is clearly going smoothly so far.
Yeah.
And we're really excited to be getting a lot of data very soon.
That is really exciting. And just on that, out of curiosity, is this drug is a type of drug like for example like statins, that you're gonna have to take it as continuous as as you go, like for the rest of your life, or is it something that you see people taking it once and then like all this plaque is removed, or this oxidized cholesterol is lowered, and then is there a way that you can test that the oxidized cholesterol is lowered? And how is this gonna work? Is it gonna be a lifetime thing, or is it gonna be like, okay, we'll do a bout of a treatment and then you get better, come back a few years later?
Yeah, our vision is that you should only need to take our drug, a course of our drug. So right now we've designed it to be 6 doses of our drug, that you should need to do that once every, let's say, 5 years, because it's taken you decades to build this stuff up to the point where it's at. And so you should only need to remove it periodically. So like other kinds of damage that you may have talked about, like senescent cells, say killing off senescent cells, you shouldn't need to do that continuously. You should only need to do that intermittently. And that's our vision for how our drug will be used. And so looking sort of way ahead as like an anti-aging therapy, hopefully everybody over, say, a certain age would be taking our drug once every 5 years. Could you test for it? Yes, we've developed a test for oxidized cholesterol, both a blood test and a urine test. The blood test you can do either potentially as a screening or as a diagnostic. We're not developing it as a commercial diagnostic, but we are using it as a diagnostic in our clinical trial. And then there's a urine test to see response to the drug. Yes, we can test for it. Yes, we can use that as a biomarker in clinical trials. I don't know how soon you're going to see that coming to your local doctor's office where you can get a test for this oxidized cholesterol and ask your doctor, oh, can I get put on this drug to lower my oxidized cholesterol? We may be a little ways away from that, but I hope that it gets done someday. And if anybody out there is in diagnostics and they want to try to develop a diagnostic test for that, I'd love to talk to you and help you do it, because it's not something that we're really fixated on trying to do and commercialize. So we'd love to give that away to somebody else.
Yeah, that sounds like amazing and a potential almost new opportunity. You guys heard it first here, so reach out to Oki. But
Yeah.
it seems like you have a great vision here for this therapeutic, and assuming everything goes well, we're hoping it does. In the next 5 to 10 years, how do you envision sort of this therapeutic really reaching out to people? You said it might be a recurring therapy that people take every 5 years. Do you think that people will still be taking some of the current approaches to cardiovascular aging, preventing cardiovascular aging, or do you see this as a complete game changer, kind of like the GLP-1s, completely remodeling the cardiovascular aging market?
Yeah, I mean, of course, I hope that it will completely revolutionize the cardiovascular and aging field, disease and treatment space. At first, you're always very careful about how you roll these out, and somebody who has a serious disease like atherosclerosis, who's already under treatment, hopefully. How are you going to identify them if they're not already been identified by a cardiologist, right? So they're already going to be in treatment. So they're already going to be taking statins. So they're not going to stop taking their statins when they go on our drug. At least at first, I imagine people will keep taking their lipid lowering drugs along with our drug. The statins will slow down the progression. Ours will reverse it. Will you be able to go off your statin someday? I'm definitely not going to tell anybody to go off of it, but maybe there'll be less need for lipid lowering, for broad spectrum lipid lowering drugs in the future with our drugs.
That is really exciting. I guess I just have one final question. I know that you're very interested in getting the body rid of things that are completely useless to us. Like, for example, as we just said, this oxidized cholesterol. But you also mentioned in our previous conversation about getting rid of microplastics. Is in the horizon maybe potentially to look at, or do you have any new projects coming after this drug? Is it your full attentions on this now?
Well, I mean, we've invented this sequestering technology that's actually based on these circular sugar molecules that we engineer that have been used in medicine before, but we've taken it to the next level in terms of engineering them and making them into something that we think can be the basis of many medicines, many therapies like this, in addition to other, applications. You're mentioning microplastics, or what most people call microplastics, are really nanoplastics, just to be a bit pedantic. But in theory, we could develop things that will get rid of these nanoplastics that are building up in your body, or say out in the environment. So the same basic technology that we're using could be used for environmental remediation, or for food cleansing, or for water cleaning of nanoplastics. And that said, we're at a pretty early stage of looking at nanoplastics and other potential applications like that. But there are a number of other applications like that. There's one other drug that's similar to our technology that's already on the market, that is an antidote for a anesthesia that's used in surgery. The surgeon will give you this anesthetic, and then instead of just waiting for it to wear off, they'll give you this drug called Bridion that is built kind of like our drug, at least with the same kind of matter. And it acts by the same mechanism, which is that it grabs onto an anesthetic, one particular anesthetic agent, very specifically, just like our drug is designed to do just for oxidized cholesterol and not regular cholesterol. It grabs onto this anesthetic agent, and then the patient pees it all out. They wake up faster, they feel better, they don't have a hangover from the anesthesia. But there's like 20 other anesthetic agents that don't have antidotes for them, because hardly anyone uses this kind of technology that is supposed to, unlike in the movies, it's like, oh, you got bit by this or that, like go take the antidote. Well, there's not an antidote to most poisons, right? Usually the antidote to poisons is like monitoring the patient and making sure they're well hydrated and stuff like that until it like wears off and hopefully they don't die or take a lot of damage from it. But the kind of technology we're doing could be used as a antidote for a number of toxins. They could be anesthetic agents, they could be street drugs. These are things that we're looking at all at a pretty early stage. And so there's a lot of different targets like that. We definitely don't have the resources to chase all of them. We're chasing a few of them. We've got a great computational chemistry platform for simulating all of this, and a chemistry platform for producing these molecules and then testing them in our labs. It takes a long time to build a new drug, though, and so it's going to be a few years before our next drug candidate gets to people. But we're hoping to have 10 more drugs based on this technology in the next 10 years.
So what I'm hearing, okay, is that you have the potential of developing a anti-hangover drug.
An anti-drug drug, maybe not for alcohol, but for a number of different kinds of narcotics, our technology could be effective against it in theory, and we're testing some of those now.
Well, I'm now definitely not trying any narcotics, but I might take a drink after. But this has been amazing. Okay, this has been a fantastic conversation, and thank you for taking us through some really amazing science today, talking about oxidized cholesterol, which a lot of people may not be aware of, and how it might reshape our fight against cardiovascular disease. So thank you for joining us today.
It's been a pleasure. Thanks so much for having me.
Yeah, and to our listeners, if you enjoyed today's conversation, don't forget to subscribe, share, and join us next time as we continue to decode longevity. And we're going to have the notes for Oki's paper and more information about his trials in the notes. Thank you. And I'll see you next time.
Thank you.
Thanks. Bye.